Well, thank you all for staying. I want to thank Jerry for a delicious lunch. I want to thank Bill Hieronymus and Cheryl and Jeff to make sure this works. And so what we're here to talk about is end-of-life care. And so the first thing I'll tell you about is what I'm going to talk about. So I'm going to talk about end-of-life care, what it is, who I am to talk about it, and why we should talk about it. Then we'll talk about healthcare models. Now, I don't mean Medicare or United Healthcare. I'm talking about what is the model your doctor is using when you go to his office? How is he taking care of you? How does he see your ends? Then we'll talk about palliative care as opposed to hospice. There's a lot of confusion about that. Then we'll talk about medical ethics, which is the heart of the matter. And the takeaway message is medical ethics just aren't for doctors. Then we'll talk about some practical things. What's a PULSE form? What's an advanced healthcare directive? And save all your questions for last, so in case somebody gets bored, they can leave. Okay, so what is end-of-life care of unnecessary suffering? It's the elimination of it, it's the prevention of it, and it's the treatment of it. Now, I didn't say necessary suffering. I mean, in healthcare, there's necessary suffering. But unnecessary suffering is the suffering you do that leads to no positive end. So there's two types. There's physical suffering, which everybody is familiar with, and it doesn't achieve anything good. Now, it means good in two ways. Good, the adjective, and good, the noun. And when we get to medical ethics, we'll talk about good, the noun. That is, what's the good the patient wants to achieve with their care? What's the good the doctor's trying to achieve? So if there's no possibility this suffering is going to achieve anything, it's unnecessary. The other unnecessary suffering is emotional. Now, this slide's a giveaway for a very important point. When people get sick, the sick person necessarily gets all the attention. But they don't do all the suffering. The caretakers do a lot of emotional suffering. And one of the purposes of end-of-life care talks are to make sure the caretaker gets taken care of. In a couple slides, I'll show you why that's important. So, they're suffering for the sick, they're suffering for the loved ones, and there's sufferings for people who provide the care, especially nurses. Now, the reason to talk about suffering is when people torture you, they don't tickle you or feed you good food, they make you suffer. And you say, well, what are the components of suffering besides pain? There's several, especially emotional suffering. There's first, a lack of expectations. Why are expectations necessary? Because if I tell you what to expect, you can develop a coping strategy. So Greer falls on the floor, take out his appendix, they sew him back up. He goes, oh. I said, Greer, in 24 hours the pain will be gone. What does Greer do? He develops a coping strategy. I'll get through the next 24 hours. But if I don't tell him, he's just laying on the floor here in pain. So that's the first thing, lack of expectations. Then there's lack of control. Anybody who's been to a doctor knows you walk into that office, you lose control of your life. And what's wrong with that? If you don't know what to expect and you can't control it, you feel what? Helpless. And in your brain, next door to helplessness lives hopelessness. And when those two get together, they go down in a dark part of your brain where fear lives, and they wake fear up. And a lot of unnecessary suffering is fear. Now, I should also tell you, if you've ever been a caregiver, fear dresses up and masquerades itself as anger. Yeah. Many, many angry people are scared to death. And in my career, I have said many times to angry people, why are you so afraid? And the reason people get angry is they don't want to deal with it. So what they do is they keep people away. So if you're dealing with somebody who's sick, who's angry, they're afraid. And if you treat them like they're angry, it doesn't assuage their fears. What do? They get more afraid, they get more angry. So, who am I to talk about it? So I practiced medicine roughly 40 years, pulmonary and critical care. So in my office practice, I had people with lung diseases that were chronically ill, they were in some stage of dying, but they were dying slowly. Then I'd walk across the street to the ICU I worked in where people were trying to die in a hurry. But in both practices, there came a time when you said, we can't do anymore. We can't do anything that makes you suffer necessarily. And so you had to have the hard discussions. So I had a lot of them in my lifetime. And after I retired from clinical medicine in 2012, I did desk work, quality, deal with insurance companies. So we developed what was called a palliative care team. The team was to go have the hard end-of-life discussions. A doctor can't get anywhere with the patient, they would call us. But we couldn't call ourselves the end-of-life team because nobody would ever consult us, so we called it a palliative care team. But it's not palliative care as I'm going to describe down the road. And some of those talks we had, I'll discuss in this talk. Because all I can tell you is the giveaway is, no matter what you think, people are never ready for death. I mean, God designed us to live. And then, about 5 months before I retired, COVID was going gangbusters. Beebe was a 250-bed hospital. They thought we'd have 400 patients. So they called the old people out of retirement. They called me out of retirement. Come back to work in the ICU. And there were a number of very difficult ethical issues that came up. And one I'll talk about is, we had a 20-bed ICU. And all 20 beds had ventilators running. Then, on my third day, a woman comes to the ER, very sick with COVID, and within a half hour we had her intubated. And we had her on very complicated ventilator settings. And people said, we can't leave her here. I mean, the ER is uncontrolled chaos. The ICU is kind of controlled chaos. So they said, we got to bring her up, but there's no bed. So that led to discussion like, well, who can we kick out? And everybody's attention was drawn to this 90-year-old person who was a good 90-year-old. And she had been in the ICU for 2 weeks, gone nowhere. But that wasn't uncommon with COVID. So people said, we should take her off the ventilator. Well, that was one choice. The other choice is, well, we can leave this woman, this young woman who was a mother in the ER, which she would get inadequate care. So what do? You take one off, bring one up. So I'm not going to tell you the answers, so we have to stick around for the rest of my talk. And what you want to find out is, what are the goals of care? Most people never think about this. But they haven't changed for 2 millennia and a half. First of all, is to remove suffering. You go to see a doctor, you go to the ER because you are suffering in some way. And what do? You want to lessen the violence of the disease. You want to heal it. But most of all, you don't attempt to cure people who are mastered by their disease. If the disease has won, you're going to die. So the trick is, how do you take care of people who are mastered by disease? They're not going to get better. They're just going to get worse, and that's what this talk's about. So if you bullet point this, the goals of care are 1, to relieve suffering, 2, to prevent unnecessary suffering, and 3, to restore life. Now, some of you probably said, what about save a life? Don't you always want to save a life? Well, the answer is, it depends. Now, all of you are feeling healthy and well right now, so we're not talking about you. So, why do you want? What you want to do is, what do people want? I go in a hospital dreadfully sick. What does Judy want? She wants me to come home, be her husband, sit down, have a cup of coffee, however long it takes for, but as long as that's a possibility, she wants me treated. So what you want is, you want a family member back, you want a neighbor back, you want a father back, you want a husband back, and so on. Well, treating the disease may not be the same as relieving suffering. I ran ventilators for 40 years. Ventilators were wonderful things. They saved people's lives. But I never met anybody who had been on a ventilator who said, I volunteer to go back on a ventilator again. Okay? So treating is not always the same as relieving suffering. And keeping people alive isn't the same as relieving their suffering. Sometimes you keep people alive and all they do is suffer more. And if it's unnecessary suffering, well, what? You're not achieving any good. So you don't always want to save a life. You want to restore a life. And lastly, being alive is not the same as having a life. And I can't tell you how many times people said to me, when do I get my life back? I want my life back. This isn't living. And guess who gets to make that choice, what living is? You, the patient. When we get to medical ethics, you get to see you actually have choices. So, if you graft unnecessary suffering, you say, okay, each of these little dips is a hospitalization. And as you see, after each hospitalization, the patient doesn't get their health back. After each hospitalization, they're worse off than when they came in. And back in the early 2000s, and I tell you, I did utilization, there was an intense interest about what do you do with people who could only be in a hospital and can't go home? For a lot of reasons. One, they were miserable, but two, it cost a lot of money. And so part of the thing is, what you like to know is where it says health status, this person's already half dead. They're down at the 50% marker, and it's downhill. And you think, well, wait a minute. 6 hospitalizations in 6 months to do what? Die in a hospital? And Adrian could tell you, if you ask the patient who's sick in a hospital, what do you want? They always say the same thing. I want to go home. I want to go home. I want to be home. And I can't tell you how many times I heard, if I knew this would have happened, I never would have came to the hospital. So end-of-life care is about not coming to the hospital if it's not going to do you any good. And the other reason to talk about end-of-life care is death doesn't make an appointment with us. Now I have end-stage lung cancer. Doctor says, you're going to die in 6 months. Well, it doesn't mean I can't die of something else along the way. So you can't say, okay, well, I'll talk about the life of Michael in 5.5 months. I'll deal with it. No. I mean, pretty much everybody here is in the zone. 40 years ago, you had 40 years to live. Most of you don't have 40 years to go. Although when I present some census data, you'll see maybe you do. The other thing is, being dead's not the problem. There's hundreds of people out here we don't hear from ever. We spend a lot of time in church. They don't speak up. Getting dead's the problem. And when people say, I'm afraid of what? Dying. So I started practicing back in the 70s, before smoking was bad. People would come to my office with cigarettes rolled up in their shirt sleeve, in their pocket. And I would say, if you keep smoking, you'll die. I said, okay, doc, I don't mind. I'll just smoke and drop dead. And I go, If you drop dead, it'd be okay with me. It's getting dead's the problem. Now, the next slide is probably one of the most important ones is, death happens to the living. When the patient dies, they're off the board. They're off in Jesus' presence, or where else they're going to go. And people don't consider this. That's why end-of-life care discussion is so important is, who's left to deal with the death? Not the dead person, the living. And that's really important. Because part of end-of-life care is to make sure that people who are going on are in the best shape possible. Or you're in some position to heal the damage that's been done. And I don't have a dictionary, but I've seen a lot of people's lives end badly. Ain't it sad? People have woeful is calamitous grief. And I would always tell people, if you have any questions, call me. And probably 30% of the time, 40%, I would get a call. Dr. Salvatore, I brought my husband in Tuesday morning. If I brought him in Monday night, would he still be alive? She's been sitting there every morning thinking she failed her husband. Or, if we never had this operation. And so people, so the idea of the end-of-life care is to say, okay, death always hurts. The idea is you can make it hurt less. And so part of the problem gets up when people say, I wish I was dead. That's pretty normal. End-stage disease makes people desperate. Remember what I said, hopelessness. And so basically, part of end-of-life care is you not only treat the disease, you have to treat the despair. If you ignore the depression, guess what? It gets worse. You ignore the fear, what happens? It gets worse. And so desperate people will try anything. Okay, so it used to be called physician-assisted suicide. It's now called physician-assisted death. I just didn't update the slide. But it's legal in 9 states and Washington, D.C. And I'm not here to talk about this, but I'm here to make the point to say, wow, what kind of shape would you say to the doctor, kill me? Put me out of my misery. How do you get in that state? But there's something worse than that. There's something called voluntarily stop eating and drinking. Now, they put this book cover, they put a nice sunrise or sunset, depending on your point of view. And what that is it's people say, I want to die. What they do is they starve themselves and die of dehydration. So, I know from reading about starvation that starvation is not a bad way to die. If you go on a hunger strike, you're miserable for 7 to 10 days, then guess what? The hunger stops. You don't feel too bad, you just feel kind of listless. Okay? The suffragettes in England knew this, but their jailers knew it too. And what would the jailers do? They would run in about 2 weeks, jam these big rubber hoses down their stomach and feed them. Not because they wanted them to die. They wanted them to go away. But what they knew is if they refed them, the hunger pangs came back. And the suffragettes would say, then the real misery set in. But that's starvation. So let's say I said, I don't like Greg's preaching. I'm going on a hunger strike. Well, I'll be up here 7 weeks before I die. They'll be having services around me. It takes a long time to die of starvation, as long as you're drinking. But if I say, I'm not going to drink, notice, political people don't go on dehydration strikes because you're dead in 7 days. But because you die in 7 days, guess what your brain does? It doesn't say, okay, the thirst gets worse and worse and worse. If you read people who got stuck on lifeboats in World War II, they suffered horribly. And that's why when you read history, men are dying of thirst. They will rush to a river to drink muddy water while arrows are coming down because the thirst is so powerful. And so, my heavens, you'd say, if you're already suffering, why do you want more suffering? It's not to say these people are misguided. It's to say their suffering is not being relieved. They're trying to stop their suffering any way they can. So this is a symptom of a failed system. And it wasn't, I've probably seen a half dozen people, people say, oh, we'll do this. And then finally, after their lips are cracked, and their moment, the family brings them in and says, we can't handle this anymore. But that's it. These things are available because people are suffering. And so what's important to know is I would have patients, their wife would die, they'd lose their finances, they would get cancer, and their dog would die. And they come to see me and they say, how are you doing? I'm okay. Everybody knows okay is code for I'm terrible. And I would say to them, you would be crazy if you weren't depressed. And a situational depression is normal. If you're in depressing circumstances, your brain says, wow, this is depressing. And that gets to be important how you treat people. Because death isn't a treatment for depression. Okay? Somebody says to me, I want physician-assisted suicide. Are you depressed? And what's important about this is, back in the early 2000s when pain relief you had all these people that said, I want to die. I want to die. Put me out of my misery. And what did they do? They got together and said, okay, we'll get the best pain relief methods and we'll treat their depression. 5 studies, thousands of people. I stopped counting at 5. And guess what? You relieve their pain, you treat the depression, they don't want to die anymore. So what's that? What are they dying from? Unnecessary suffering. So, and the trick is, how do you provide hope in a hopeless situation? You come to see me, I say, I'm sorry, we can't do anything. You got 3 months. You don't say that and say, I'll say, and I give you an appointment for 6 months. You say, wait a minute. This is what we're going to do. I'm going to tell you what to expect. Yes, you have pain. We'll give you medications for your pain. We'll get you hospice. Here's my phone number. You call. We'll have nurses come to your house. Anything goes wrong, call us. You tell them what do? You give them some control. So, Adrian's here. Meanwhile, Greer's still laying here. Oh, I'm in pain. So she runs out to her car, comes back with a bag of morphine, what's called patient-controlled anesthesia. We hook up with an IV, and he's got this button. Now he can push this button and relieves his pain. Guess what? Greer's happy. And he's using less morphine than I was getting before. And even when he pushes the button and gets nothing, he still feels better. Why? Because he has control. Now, one of the bad things in life, medical, politics, everything, is people do things by how they sound, not what they mean. And death with dignity is one of these things. Do you believe in death with dignity? I do. I believe it. But what is it? Well, death with dignity is actually something very specific. It's the right of a person to be valued. Now, in a couple minutes, I'm going to talk about something called moral worth. You all have it. And you have a right to be respected. And you have a right to be treated ethically. Okay? That's death with dignity. Death with dignity is say, I have a right to die. Wait a minute. You have a right to be treated ethically. You may say you want to die, but my obligation as your doctor is to say, well, why do you want to do this? Okay? You know, when Greer got over his appendicitis, and Jean says, so depressed, Greer's back home. She tries to kill herself. So they bring Jeanine to the hospital as an attempted suicide. What do we do with her? After we treat her, we don't send her to jail. We don't think people commit suicide are criminals. We send her to psychiatric hospital. It's probably worse than jail in Delaware. But anyhow, so suicide is not a crime. Suicide basically is a sign of something's failed. So, you can tell how old this slide is. I've been giving a talk like this probably for 15 years. And I don't know if there's any ethical slopes. Now we have ethical precipices. They just drop off. But clearly, when you're desperate, when you're hopeless, things get blurry what you'll do. Plus, what's ethical these days, or what passes for ethical, is not clear. And there was never a better... Probably everybody remembers this is Jack Kevorkian. Now, I'm not a lawyer. It took Jack Kevorkian executed 4 people. He had 4 trials, 3 hung juries. Finally, he was convicted of 8 counts of manslaughter. But I don't want to talk about the legal thing. What Jack Kevorkian did was, he was unethical. Greer comes to me and says, my appendix hurts. I want you to kill me. What do I do? I see if Greer's depressed. Do I relieve his pain? He just killed him. And his little bottle, the 2 tubes, he called that his thanatron. The Greek for Thanos is death. So, the first woman he helped die was a woman in her early 50s who thought she had early onset Alzheimer's. So she climbed in the back of his van, and he killed her. And actually, he actually killed people in a more humane way than most states could execute their prisoners. But it was unethical, highly unethical. But Jack Kevorkian, like everything else, he was a symptom. Why are these people turning? Why would you go to some wacko pathologist who never took care of a person in his life, who only did with dead tissue? Because he drove his Volkswagen van through a big chasm in medicine. Unmet needs. So the other reason you want to talk about end-of-life care is because the hardest thing to do is let a loved one die. Now, there's an apocryphal story from Pennsylvania where one day a lovely woman took her lovely cat to a lovely veterinarian. And shortly thereafter, her husband, this lovely doctor, got a call. And the lovely veterinarian said, we have your lovely cat here, and we need to euthanize it, but your wife can't give that permission. She wants you to do it. Because his lovely wife was empathetic and compassionate, so the less empathetic and compassionate husband said, yeah, kill the cat. It's not easy. It's not easy. And anybody thinks that my wife is just a coincidence story?
It was me.
The other important thing is, and don't forget this, I'm going to talk about it again. The easiest thing for me as a doctor is to do everything. Just start and never stop. Okay? That's easy for me. And guess what? You know how many times in my life I've been told, I went to Dr. So-and-so, he did something. Doesn't matter whether it was worthless, he did it. Because somehow I failed to communicate with them that it wasn't worth. So when you go see a doctor, when I talk about healthcare models, what model is he operating on? Now, this is particularly germane to this group. In 2010, the Census Bureau did something called the next 4 decades. And what they said was there's 40 million people 65 and older. By in the next 40 years, it will increase to 100 million. So guess what? In 2020, we did another census. And the 65-year-olds increased by 14.9 million. Right on track. At least this census knew how to count. Now, in this census, they said some other things. The number of people in our country in 2010 over 100 were about 150,000. Be 500,000 in 2040. Maybe some of us. Maybe Greg will still be preaching when he's 100. I don't know. But the other thing they said was, in the census, there's a group called the oldest old, 85 and above. They're going to increase treble, the oldest old. Now, the problem with being the oldest old is this. As I look around the room, maybe Jeff and Cheryl are the closest thing to tennis balls. And most of us, we've outgrown being tennis balls. What's the difference? You take a tennis ball, you take a 30-year-old man, you get him sick, bam! You make him sick as a dog. What does he do? He bounces back on the table. He might be on that table for 3 months in the hospital. He bounces back. Now, you take the good-looking 85. I always hear that. Always a good-looking 85. That is. You're a good-looking 85. But that's like a ripe tomato. It's a good-looking tomato. And if you, bounce the tomato, the tomato does okay. But then you walk up with some catastrophic illness. And you say, okay, tomato, boom. Some tomatoes do bounce up. Most tomatoes don't. They splatter. And once they've splattered, for the most part, all the king's horses and all the king's men and all the doctors can't put them back together again. What it means is, when you're 85, all your parts are 85. They are things that age in you, you can't control. That's just part of aging. You can take better care of yourself. You're in the best shape you can, but the age-related deterioration still happens. When you're 85, you've got an 85-year-old immune system. You have an 85-year-old heart. You have 85-year-old lungs and liver and pancreas. And that's if you're healthy. So just remember. Now, I once had a problem. Woman came in, got intubated at home, 105 years old. So within 24 hours, she wanted to get better. And I was talking to the family. What did the family say to me? She just had her birthday. They had 5 cakes, each with 20 candles, and she blew out all the candles. And they said, and then I told them my ripe tomato story. Because we're all old heads here, but we don't see it. I mean, Judy and my wife would tell each other, I don't feel 74. But somewhere in my body, something feels 74. Now, this is really important, why you need to talk about it. Because patients and loved ones don't always agree. Now, here's a great unspoken truth. Disease and dying doesn't make people better people. Some people think when somebody starts to die, they'll somehow become noble. No. Disease and suffering makes them more like themselves. So if you want to know, how am I going to handle my dying? The same way I handle a flat tire in the rain. If I get out and say, oh, I'm so happy this tire's flat, I'll change it. But if I get out and I kick the tire, that's how I'm going to handle it. Now, some people do rise to the occasion. I've had patients who say to me, I want to show my children how to die. But most people, because they're suffering. Now, the other thing is, loved ones and loved ones don't always agree. And that's really important in Delaware. Because Judy and I have 12 kids. We only have 2, but I'll say we have 12. Now, I die. I'm in a hospital. Judy gets to call the shots. Doesn't matter what the 12 kids say, she decides. But then she dies. Guess what? In Delaware, it's up to the 12 kids. Not the oldest, but all 12. You think that's complicated? Wait till you see a guy has 4 kids by this wife and 4 kids by this wife. The first family always thinks they get that. Or, worse yet, the second wife's alive and she gets to make decisions for the first family. It's very complicated. If you don't think it's true, just think of all the horror stories you heard about estates and wills. So, you got to talk about it beforehand. You may not agree, but you'll know what you're going into. Now we'll talk about healthcare models. And this won't be on. So there's a default model. Dichotomous means they're contrasting. And then there's the integrated model. So this is the old-fashioned model. This is kind of the model when I practiced in the 70s. You just treat till people die. This is where the only goal is save the life. Keep them alive at all counts. So preventing death is the goal, what it takes, everything. Remember what I said, the easiest thing to do in life for a doctor is everything. So the patient has the disease, the patient and the disease both get care, but the disease gets all the care. The patient doesn't. And what's the consequence of that is people are surprised when somebody dies. I have had patients who come to see me the year before. You have uncurable lung cancer. They undergo chemotherapy. They undergo radiation. They undergo multiple procedures. They come back a year, I said, oh, your cancer's back. Cancer? You never told me I had cancer. Why? Because we survive bad news by what? Denial. You go home now and you drive your driveway and your house is burnt down. You find out all your investments are gone. You have notes from your kids that say they never want to see you again. Your dog is left home. You say, most people don't just fall on the ground. People say, okay, how can I deal with this? Because you deny the problem. That's how you survive. Greg and I are out fishing in his little leaky boat. And the boat sinks, and we can't see land. And I'm trying to hit Greg with an oar saying, why'd you bring me out here? And what do? We don't say, oh, we're too far for sure, let's drown. No, we start doggy paddling. Why? Because we're denying how bad it is. Denial. And so denial, and of course, if I'm treating your spouse or your loved one, I'm not telling you they're going to die. You're not ready for this. You think they're going to go on. And this is terrible. So the next model is the dichotomous model. And basically, this is where you treat people until they're almost dead. This is where you've had a disease for a year. You go in a hospital, start to say, okay, we need hospice. So you treat until death is on. Even the clean people know the patient's dying. So once death is inexorable, the patient alone is treated. And when I used to go talk to people, and I'd say, we could have got you on hospice 6 months ago. What did the families always say? I have heard this so many times. Why didn't somebody tell us? We never would have brought him here. Why didn't somebody tell us? Now, the model gets a little more complicated, but it's quite simple. Pay all your attention to the rectangle. By the time you get to the triangle, the patient's dead, so you don't have to worry about that. And what this says is, underneath it says, disease-modifying therapy and disease progression. In the center, there's an arrow. So at the beginning, there's zero palliative care at all treatment. But as the disease gets worse, there's less medical treatment and more palliative care. So we're going to talk about palliative care. Because it's just what it says. You want to palliate the disease. I should go back. What's important here is, from the moment you come in, you anticipate dying is going to occur. Okay? Now, when you tell people they're going to die, They never, never, never get angry at you and say, what, I was wrong. You're going to live. But if you tell them they're going to live and they're going to die, they do get angry. So, man comes to my office, he's got end-stage COPD. And I tell his wife, I can't do anything else. We'll get him on hospice. I don't know if he'll live till tomorrow. That's one scenario. On the other hand, I say, he's okay. I'll see him in a week. So one, he may die by tomorrow, or I'll see him in a week. She goes home middle of the night, he dies. If I say, I don't know if he'll live till tomorrow, she says, well, that's what you told me. If I said, come back in a week, she said, why didn't you tell me? What didn't I do? I didn't tell her what to expect. And she couldn't develop any coping strategy. So palliative care, basically, while you're treating a patient, you're preventing unnecessary suffering. You avoid overuse, misuse, and abuse of therapy. Just because it says it's treatment doesn't mean it's good. Now, the downside of this is when I would go talk to patients and say, Mr. X, we need to get you palliative care, and say, I'm not ready for palliative care. Because he thought we were talking about hospice. Well, all hospice is palliative care, but not all palliative care is hospice. Palliative care is very specific. You're dying in the next 6 months. Palliative care is symptom relief, to make you comfortable, to support you, to support your family. You can do that anytime. And at the end of the lecture, I'll tell you where you can get it, and if you're not getting it, how you can get it. So palliative care is the umbrella. Hospice is a subset. So palliative care is focused on providing relief from symptoms and stress. And this is stress for the family, too. And what you want to do is preserve the quality of life. Remember what I said, being alive is not the same as having a life. Being alive is having a quality of life. So, if you look at this model, first of all, it tells you hospice shouldn't be a last-minute decision. Now, there are some people who are perfectly healthy, fall off their bicycle, go to the hospital and say, oh my heavens, you have cancer from your toes to your head. That's not much. You can't help that. But if your cancer starts in Dover, and you're driving with your cancer to Charleston, South Carolina, it should be no surprise that your cancer is getting worse. And when you look at this model, and people have done these studies, you say, okay, here's a group that gets treatment and palliative care. Here's another group that gets treatment and no palliative care. Same treatment. The people who get the treatment and palliative care actually live a few months longer. That's but a few months. But most significantly, the patients are less stressed, the families are less stressed, and their grief is less. It's a good model. Now, we're going to talk about medical ethics. And one of the things to understand is too much treatment is unethical as too little treatment. So, if somebody would come in a hospital with bad asthma, and I didn't give them high doses of corticosteroids to try to save their life, they'd say, oh, Dr. Salvatore, he didn't do everything he should have done, which would be true. But if it's a 105-year-old person with asthma who's got bilateral pneumonia and a bad heart, and I intubate them, I'm in both things. So doing too little is bad and doing too much is bad. So being what's called a treating doc is good in some circumstances and not in the other. So you might think I haven't read a medical journal since 2,500 years ago, but Hippocrates made the point, the treatment's not the pampered disease. I just love that. Because once you've been mastered by your disease, anything I do just pampers the disease. And pampering happens because being able to do more is confused with being competent. Wow. I ran ventilators for my life. You run a ventilator, you can vary the volume, the rate, the amount of oxygen, how much CO2 goes in, how long is the inspiration, how long is the expiration, how much pressure to leave in the lung, negative pressure, positive. You can do all kinds of crazy things. But the only reason to do that is if it comes to some meaningful end, achieves a good. There's a scene, anybody ever seen the movie Indiana Jones? So there's a scene in Indiana Jones. He walks into this village, there's a crowd, and this guy jumps out with a sword. He does all these fancy sword movements, flips up in the air. He's an expert swordsman. Indiana Jones pulls out his gun and shoots him. Indiana Jones is death. The fancy swordman's the doctor who's showing you everything you can do to no end. So there's a limit beyond which, no matter how competent you are to what you're doing, it's unethical to do it. And so Albert Johnson died this year. He was a ex-monk who became an academic, but he wrote wonderful stuff about bioethics. And so overtreatment is actually a sign of incompetence. No, I know that for a living because when I worked in the ICU, who washes up in the ICU? People who have catastrophic illnesses and people who've been overtreated. And the thing is, once they get in the ICU, it's my problem. I'm the attending doctor. I get to make decisions. So, overtreatment is bad. So, this is sort of the immediate thing. There's sort of ethical imperatives about why you want to reduce unnecessary suffering. And there's three of them. The concept of natural death, the doctrine of double effect, and moral worth. So, there's nothing wrong with natural death. Is a biologic event that's morally neutral. So, I have somebody, they have end-stage lung disease. They say, got a pneumonia, say, if we're going to keep you alive, we need to put in a ventilator. Say, I don't want to go on a ventilator. That's their choice. Now, not everybody gets a choice. For instance, I had a 52-year-old guy, perfectly healthy, walked into my office, he had asthma, saying, I'd never want to be on a ventilator. His father was on a ventilator for 3 months. He didn't want a ventilator. He also had teenagers. So I said, well, we'll talk. So what happens? One day he rolls in the ER, status asthmaticus, you can't break his asthma. And he kept saying, no ventilator. And his wife says, save him, you can't let him die. So he's very clearly made his wishes known. She's very clearly making her wishes known. So what do? So what you do a lot of times is you fudge it. What I mean by it is I went to him and said, look, I know you're afraid of a ventilator. I promise you, I will knock you out now, and in 3 days I'll wake you up and get you off this machine. You won't even know you're on it. No, I was just guessing. I didn't know that would work. But he bought it. And we woke him up in 2 days, and what did he say? That wasn't so bad. So but you have to deal with that. So some people have a right to natural, and he would have a right actually ethically to say, I don't want to do that, but you say, wait a minute, there's a cost. Because when people do physician-assisted suicide, when people choose to go to Jack Kevorkian, what happens? That death happens to the living. So the living have an obligation, the dying have an obligation to the living. So, basically, if keeping somebody alive only makes them suffer more, it's okay to let them die. You keep them comfortable and let them go. There's no other choice. If the choice is to make them suffer more unnecessarily, that's not a choice. Now, if I was giving this talk at St. Jude's, he would be St. Thomas Aquinas, but since we're a Reformed church, he's just Thomas Aquinas. So Thomas Aquinas had this principle of double effect, which is it's your intent, not the result of your actions. So, Greg said, I'm sick and tired of you bad-mouthing my preaching. Jumps up, rushes me one of those plastic forks, and like Indiana Jones, I pull out my pistol, shoot him. Well, I'm not guilty. I'm not guilty of murder because that was self-defense. Okay? Now, that was a sharp plastic knife, by the way. But where the rubber meets the road is this. So when you give people morphine for pain, it's ethical to do that. But it's not ethical to say, I'm just going to put them out. I'm going to knock them out, die. So how's double effect work? So normally, it takes this much morphine in your brain to stop breathing, and this much to relieve your pain. So you get the morphine level up here, you're okay. But as you keep giving people more drug, the drug accumulates, and now the pain level's here, stop breathing's here. So now they're like, you almost have to knock them out. But if you have somebody where they're going to stop breathing here, the pain relief's here, guess what? You having a morphine drip, they die. But that wasn't your intent. But if there ever was a slippery slope, and I can't tell you how many times people said, can't you just give them a little more, doc? And you can't. For a lot, one, it's unethical. It's criminal. But two, what they think is a good idea when they're in desperate straits, next morning, in the light of day, would say, no, oh my God, I killed my father. So, as a doctor, you have to say, okay, what am I doing here? It's not okay to give people more than they need. So, I'm happy to tell you, you all have moral worth. And this is something that's basically soaked into your bones. A moral right is a person not to be capriciously harmed. And you've seen those red letters before, treated ethically. And you don't think this is a deep thing? So I'm up here, all of a sudden a cockroach come out. People say, kind of rude, but no big deal. But then I jump down and go back to Jim Athey and start stomping on his foot. People say, he can't do that, stop doing that. Why? Because the cockroach has no moral worth. Jim does. So how strong is this? Jim Athey's driving home and said, you know, if I know he's going to stomp on my foot, I never would have come to that talk. He's driving down Route 9, and there's a dead possum. And Jim's saying, these possums are so stupid, they're always getting run over. Please just drive by. Another mile goes by, there's a dead Labrador retriever. And all of a sudden, it's not the same as the possum. Because Jim says, gee, that dog belongs to somebody. Somebody who has moral worth. They're going to be harmed by the death of this dog. That dog has what's called secondary moral worth. The same moral worth I have is if I just boom, drop dead, you don't say, oh, take him out to the dumpster. You say, oh, no, let's have a memorial service. Let's put him out here with the dead. Because even my body has secondary moral worth. But now Jim keeps driving. So it's a bad drive home. And all of a sudden, oh my heavens, there's a baby in the side of the road. The baby's dead. Slams on the brakes, runs out, covers the baby with his blanket. Says, oh my God, this is awful. Calls 911. 3 dead bodies. They're all dead. But 3 different reactions. That baby has moral worth, intense moral worth, the most moral worth. Right away, the baby has moral worth. The baby's dead now, but the mother has moral worth. The father does. The family does. This is really a very strong thing. So, when you go back to death with dignity, dignity is to be treated ethically. It's not some flippant term to say, oh, I believe everybody has the right to die. No, they don't. They have a right to be treated ethically. It's not the same thing. Go back to Janine. She thought she wanted to die. That was yesterday. Today she doesn't. Okay? So, we finally get to medical ethics. 4 medical ethics, actually 5 as you'll see. So justice breaks down into 2 things. There's social justice, which means you respect all patients. No matter what the patient does, you have to take care of them. Then there's distributive justice, which means you have so much medical care, you distribute it justly. So, social justice. I have to provide the care the patient needs no matter what. So, Greg's a Pittsburgh Steelers fan. I hate the Pittsburgh Steelers. I'm an Eagles fan. Sunday, the Pittsburgh Steelers beat Eagles 95-0. And I'm really angry. And all of a sudden, he called me here and says, Greg's here, so I get there. And there he is. He's got a Pittsburgh Steelers jersey on. I said, I'm not taking care of him. I don't do that. I have to take care of Pittsburgh Steelers fans. People are HIV positive. people have AIDS, doesn't matter sexual orientation, if the drug addict who took an overdose. And does anybody know what in medicine there's Super Bowl Sunday syndrome? So Super Bowl Sunday syndrome occurs during people who get dialyzed Monday, Wednesday, Friday. So people with dialysis have end-stage kidney disease. They need dialysis to take off excess fluid. But their longest stretch is from Friday to Monday. So here comes a Super Bowl, or perhaps any football game. They sit down with their friend. They eat potato chips with lots of salt, pretzels with lots of salt, hamburgers, a couple beers. They fill up with fluid, their lungs fill up with fluid, and then it's Dr. Salvatore. We had your Pastor Greg on a ventilator here. He abused himself before dialysis. So I can't say, he did that again. I'm not going to say, I have to see him. I don't have a choice. No matter who the patient is, and there's some real life things. I was chief of staff once at BB. I called the ER because there was a grandfather at ER who was pretty sick, and unbeknownst to me, he was a child molester. He molested his grandchildren. And everybody knew it. I mean, there's no secrets in Sussex County. Nobody would touch him. So I admitted him. But that wasn't right. But it doesn't matter. No matter how despicable people are, they have what? Moral worth. Did we what? Treated ethically. And so basically, whether you're Republican, whether you're Democrat, whether you're vaccinated, unvaccinated, you have the same moral worth. Now, distributive justice means you give the care where it goes best. So in the military, you get to do with triage. So during the Civil War, somebody would stand there and say, okay, put him to the doctors, him to the death tent. They put him in a tent someplace where they're just going to die. World War II, they'd have medics or corpsmen, as they bring people in, they'd say, to the doctors over here for comfort care till they die. When I was a young corpsman in Vietnam, there was an accident on a highway in Vietnam. Truck rolled over in the rice paddy, multiple injuries. And so they were medevacing everybody out, and all the helicopters going. And finally, we had 4 people left. And they were kind of hurt, but they weren't the worst hurt. We got rid of those. So we called for a medevac, and one medevac was left, and it said, we can take 3. And so we said, okay, let's let this guy, we'll put him over here. And then the lawyer, they called up and said, we can take all 4. We have a pending permanent routine. Permanent routine was a medevac you call for somebody who was dead. No hurry. They're not going anywhere. And so the helicopter landed. You took this guy who was dying off, and you put all 4 people on. Nobody complained about that because people understood. You do what you can for the best. Now, up until COVID, we always had more stuff than we needed. Remember, we got a 20-bed ICU, got 20 ventilators pending. We got a 90-year-old lady here and a 40-some-year-old lady here. What do? And because I had the most gray hair, they kept asking me. And what happened with a lot of medicine, the nurses solved the problem. The nurses called around and said, they got nurses who were off duty to come in. And so the ICU nurses who were off staffed the ER. And that 90-year-old lady never died. Somebody else died, and we moved this person up. The 90-year-old lady recovered, went off to nursing somewhere because, being in bed for 4 weeks on a ventilator at 90 years old is almost as good as being dead. But they solved it. But there's not always an ethical answer. Ethics aren't math. Sometimes ethics have more than one answer to the same problem. Now, autonomy means the patient gets to decide. But that's not mean the patient gets to decide everything. For the patient to get to decide, it obligates me to tell them what they're doing. If you ever had an operation, you sign what's called informed consent. Most of the time it's a joke. Somebody hands you to sign this thing. But what it's supposed to say is, I'm going to do this, and this is the good and bad stuff that can happen. So the fact that you get to decide obligates me to say, you really need to know. So inform means to communicate my knowledge to you. So I guess some of you guys are old enough to remember when doctors were paternalistic. That's what the doctor just said. Take this and shut up. Well, then people didn't like that. So they said patients should get to decide. Well, then they said, wait a minute, this isn't working so well, too, because patients are deciding, like the guy that didn't want the ventilator, that was a wrong decision. I mean, you ask them to make medical decisions where they don't have medical knowledge. So basically, autonomy, so you want paternalism here, autonomy here, and now it's somewhere in the middle where it's basically, autonomy means I have to work with them. Back in the 2000s, there was a horrible practice. There was a chemotherapy agent that was taken off the market in the United States. So in Mexico, they started giving it to people as enemas who had colon cancer. And what it would do, it would cause basically bloody diarrhea. And the doctors in Mexico said, that's a good sign, that's a tumor coming out. Well, it wasn't. It was just a wall of your bowel coming out. And so people would say, well, if I can't do anything else, I'm going to go to Mexico and get this enema. Now, they were desperate. They wanted to try something. And I said, no, you can't do that. It will just make you sick. You may die. But they were autonomous people. And so basically, you get the choice, but you need information. Your real power is not to say yes. Your real power is to say no. Say, I don't want what you want to give me. I understand what you said. I don't want it. That's your real power. Now, I talked about good before. So in ethical parlance, that's beneficence. So the goal of beneficence, everything I should do is to achieve a good. Everybody agree. And the patient decides what's good. For instance, they may not want to live as long. So years ago, I had a lady had a heart attack. And she had so little heart left, they could only keep her alive by a continuous drip of blood pressure medicines. Even when the nurses changed the bag, her blood pressure would drop precipitously. And she wanted to see her granddaughter married. I told the family, there's no way she's going to make it. So the family came up with an ingenious answer. What they did was, now they had the wedding scheduled, they had a reception. They went and got married. He had his tux, they got married at Justice of the Peace, everything. Then she came to the hospital. I saw her grandmother. Now, this is not BB ICU. So anybody heard about HIPAA violations? I didn't violate HIPAA. And once everybody went home, the family gathered, we turned to her, and she died. And what did they do? They decided when we have the wedding reception, it's a combination wedding reception memorial service. And what I was told by the son was, at the wedding reception, they had a big picture of her sitting in a chair at the table. And so they turned something horrible into something good, but that was her good. She wanted to stay alive to see that. Now, when I was doing the palliative care going around, there was a guy on a morphine drip, could not go home. They wanted us in a hospice center. He wouldn't go. His doctors wouldn't do. So they consulted us. So I used to stand inside the room and said, how should I approach this? And it wasn't by myself. I had a chaplain. There was other people with me. So I walk in the room, and there's his 4 daughters, and he's just sitting here like this. And finally I said, Mr. So-and-so, what do you want? What do you want from us? And what he said was, you can get me an egg cheeseburger. And right as soon as he did that, all the daughters started crying. And they said, our mother he used to work 2 jobs. He'd leave early in the morning, come home after 8 o'clock, and she'd always make him an egg cheeseburger. She'd said like for 30-some years. So I called food services, and BB's got a wonderful cafeteria. They made his egg and cheeseburger. And I'm looking at this guy. This guy can't swallow his saliva. So we get the thing. They bring it up. The daughter's put in front. He's got his eyes closed. We said, we have it, Dad. He pulls his head forward, goes, puts his head back, and opens his eyes and said, smells like your mother. And I start crying again. I'm crying. Everybody's crying. And the story was, he would cook a hamburger every day because what did he want? He wanted his house to smell like it was when his wife was there. And so the next question was, he said, can I get these at hospice center? And I said, you can get all you want. So we called the hospice center. Hospice center made one. They would bring it out, put it in the refrigerator, put it in the microwave, bring it out, and he died about 2 days. But I mean, that was his good. That's what he wanted. And the other thing is, this is one, everybody knows this. First, do no harm. But they think that means the doctor can't punch you in the nose, which is probably, I mean, did I ever want to punch patients? Yeah. Did they ever want to punch me? Yeah. But I can't punch them. But that's not what this is about. Medical care that cannot achieve a good. If you cannot achieve a good, that means you're causing unnecessary suffering. That means it's harm. Doesn't mean punching people in the nose. It means keeping them alive or treating them unnecessarily. Remember what I said, physical suffering without hope of achieving a good. So unnecessary suffering is harm. So, allowing somebody to die who's going to die is not unethical. But to keep them alive and let them suffer unnecessarily is. And sometimes you have to fight with families. Okay? And I'll talk about CPR in a minute. But in my career, I've seen people who look like this undergo CPR. Because if you don't talk about end of life, things like doing everything sounds good until you talk about it. So one of the reasons I have end of life discussions with the families, with the patients is, do you realize what we're getting into? Do you realize we're at the deep end of the pool now? If your mother gets out of the boat, she's not going to stand up. She's going to the bottom. Okay? So, ethical care requires foreknowing, that's me, making a prognosis. What do you pay me for? My judgment. Do I think you're going to live for a year? Do I think this? And then, once I know this, I tell you. It doesn't do any good if I keep it to myself. You need this. Why? Because it gives you predictive data. So, for a doctor, care is necessarily as long as you realize until it's not. So a prognosis gives me predictive data. The predictive data says, this isn't going to work. I stop treating. If it says it should work, I continue treating. That's my prognosis. But the patient uses the prognosis a different way. They will continue to put up with necessary suffering as long as they realize it's okay. But once they realize the necessary suffering becomes unnecessary, and how do they know that? I give them a prognosis. You're not going to live 2 weeks. We've got to stop this. Predictive data allows them to develop a coping strategy. Giving people telling them what to expect develops a coping strategy. Now we're back to this. I showed you this before, and what's important here is, the reason you want to talk about end of life is, you're the patient. You're the family. How do you want to spend the last bits of health? Do you want to spend it in a hospital? Do you want to spend it at home? There are some people, they want to die on ventilators. They want to die with chemotherapy in their face. But most people say, no, I'll be home with my dog. I want to go home with my wife. And so prediction means about the first downturn there, I say, hey, this is not going well. There's no upturn here. And so basically, the trick becomes, how do you take care of people who can't live outside the hospital? You send them home, you give them palliative care. When palliative care runs out, you give them hospice. You keep them comfortable. You don't keep bringing them back to the hospital. Remember what I said. If I knew this was going to happen, I never would have come here. So care that causes unnecessary suffering is futile care. And it's brutal to get, it's brutal to witness, and it's brutal to give. It's no fun treating people who you know it's not going to work. And some of you may have seen CPR in the street. In hospitals, it's an assault. It's a traumatic event. And if you're a nurse who's been watching this person for a week, and you know this is going to happen, and you know they're going to die, you dread it. You dread it. So what happens? They run in, people pump on the chest. I'm up there sticking a tube down their throat, people sticking IVs under their clavicle. We're shocking them. We're doing all this stuff. And then you say, you would call the code. So when I was younger, I would say, okay, if that's what they want. When I go, I said, I'm not going to do it. And I said, you can fire me if you want. So if I say, You want your mother resuscitated? I won't do it. My obligation is to find a doctor who will. I just can't walk away. But what I found out was if I said, no, I'm not going to do it, they'd say, well, what should we do? And so, but what they found out was nurses who witnessed this in their career get PTSD. It's traumatic. It's trauma. Now, it turns out veterans, the VA actually is a pretty good health system. They collect good data. What they found was vets who had untreatable lung cancer were committing a lot of suicide because all these guys own guns. And most men don't make suicide gestures. They make suicide. But when it's Institute of Palliative Care program, guess what? The number of suicides dropped precipitously. And then there's, unnecessary suffering leads to a lot of things. And I listed them before. One's not on here, and I'll mention it again. That's guilt in survivors. The other thing is people don't talk about financial stress. Like, oh, it's so cheap to talk about money. But financial burnout comes in a lot of ways. You get medical bills. In my whole career, I have people bring their medical bills to the office. I practiced 40 years. I never saw a medical bill I truly understood, but my nurses did. People lose their savings. Worse yet, they incur debt. And there's something called financial toxicity, which you may not know what it is. I first learned about it when I had a patient who was in hospice. She said to me, I'm worried about Frank. He only takes his pills in the morning. Well, Frank's supposed to take them twice a day. No. Frank would take his pills once a day so he had money to buy her medicines. So financial toxicity is where the healthy loved one doesn't take their medicines, so they have money to buy medications for the sick person. And you say, wow, and how is that possible? Well, he's not saying. And this applies mostly to men, but wives too. When it's your loved one, it is very, very, very hard to watch them being treated by somebody else and you not be able to help. You want them more than anything to care for them. You will do anything to care for them, even if it means not taking your medications. Some way to care for your spouse. So, the little cloud says, that's the doctor thinking, would I be surprised if this patient died in a year? So we're going to talk about the pulse form, physician's orders of life-sustaining treatment versus advanced healthcare directive. So the pulse form, when you're going to be dead in a year, you get what's called a pulse form. And I'm going to hammer this in. A pulse form is specific orders. An advanced care directive are your suggestions, your wishes. And in 2 slides, I'll show you the power of that. So in Delaware, in the pulse form, you only have to be alive for less than a year. Any age, kids, anybody who's dying. And I just, as a doctor, have to say, I think you're only going to live a year and need a pulse form. Judy and I have executed 2 pulse forms on her sisters. They're in Delaware, they're very easy to get. You get them online, you print it up, you fill it out, you take it to your doctor. And I'll say this again, physician's orders. In a minute, I'll tell you why that's important. A POA can fill it out. And guess what? It comes in a bright-colored envelope you put on your refrigerator. So this is the busiest slide, so I'll go through it slowly. Who completes it? You do it with your doctor and either you or your POA. When you make a living will, you do it. You're sitting there with a lawyer. Who needs one? If you have less than a year to live, you need a pulse form. No questions asked. So anybody can get a living will. Pretty much once you grow up, have kids or wife or family, you need a living will. Who appoints the POA? The pulse form doesn't. I said it's filled out by a POA. A living will appoints your POAs, your medical power of attorney. What's communicated? The pulse form is specific orders. The advanced care directive of the living will is general wishes. Most importantly, EMS, when they kick down your door and say, we're here to save a life, they can use the pulse form. The living will doesn't make a difference. So, I was sitting home watching television. I get up, fall over in a foyer. Judy calls 911. EMEs rush in. I'm in ventricular fibrillation. She says, I have his living will. He doesn't want CPR. They take it, say, thank you, Mrs. Salvatore, code him. They do CPR. Why? Because they're under orders from the hospital. They're under protocol. They don't take orders from my wife. They don't take orders from me. They take orders from doctors. Now, same thing happens. We rewind it. Now I have a pulse for him. They come busting through the door. She grabs the iron envelope and says, he has a pulse for him. They look at it and say, and what do? They say, sorry for your loss. Who should we call? That's the power of a doctor's order. That's the power of a pulse form. Now, it's really powerful because what's significant about this slide is most medical practice suits up until recently were for wrongful death. Greer comes to the hospital. He's got an ingrown toenail. I mistakenly cut off his whole leg and he bleeds to death. And Janine Souza said he shouldn't have died from an ingrown toenail. But if those EMTs bust through the door and I show them my pulse form and they intubate me, guess what? They violated a doctor's order. Or if I'm in the hospital and I code and they come and resuscitate me, they violated a doctor's order. That's called wrongful life. And there are multiple lawsuits now in the country where people have paid millions of dollars because when you get CPR, you're hoping you restore a life. But most of the time you don't. Most people in hospital CPRs die, or they survive the code and die in a hospital a week later, or they survive to go to a nursing home. Very few go home. And so if you wanted your mother not to be coded, your father not to be coded, and he ends up in Harbor Health Care because they coded him, guess what? That's wrongful life. Very powerful. In Delaware, it's called DMOST. Every state has a name. DMOST means Delaware's Medical Orders of Scope of Therapy. So I made this up. I thought, every state has a name, so I went to Alabama with maybe like almost. I don't know. But if you go home and Google DMOST, boom, the website pops up, and there it is. You just print it up, you got it. If your doctor doesn't suggest it, you print it up and you take it to them. If you have less than a year to live, or your loved one has, so I want this done. But what you do is you talk about it. The first thing you come to is, do I want to be resuscitated? Okay? It's a very powerful tool. So, I mentioned palliative care. All the major health systems in Delaware have palliative care. Beebe has it. Nanacoke and Dover has it. Christiana Care has it. Nanacoke has it. So, this says final thoughts, but I actually have two more thoughts after this. But the final thoughts is, everybody our age should have a living will. Except, Dawn's probably the kid in the room. She could argue, but you should. And don't appoint one medical POA. Appoint a couple. You can grade them. And don't appoint somebody who's older than you. Most of all, appoint somebody who thinks like you do. Now, Judy's sister just died, and she had two POAs. One was her doctor, and one was her brother-in-law. Well, in short order, the lawyer died from COVID. Yeah, we had to get more POA. So, this is the opportunity to say, this is what I want. And now, don't be surprised if you talk to your spouse or your loved one, and they say, I don't agree with that. So you got to talk that out. And if you've got less than a year to live, get a DMOST form. If nobody tells you about it, print it up and take it to the doctor. And they've been around since 2016, so they're not like news. Most of all, make sure, if you're somebody with disease, you spend your health wisely. I can't tell you how many people are dying in hospital, and we put them in an ambulance to take them home. People would spend thousands of dollars for an ambulance ride, and most of them would die on the way, but they wanted to go home. They wanted to go home. Or how many people couldn't go home? Back in the old days, you had to sneak the dog into the hospital. And I never knew it. You get off on the third floor, the patient would be somewhere out in the cemetery. That dog would take one whiff of the air, and off they go. Spend your health wisely. Do you want to have surgery? Do you want to have radiation therapy, chemotherapy? Do you want to keep being dialyzed? What do you want? Share your wishes. If you're sick, tell your family what you want and what you don't want. And if they won't tell you, ask them. You know, the original don't ask, don't tell had to do with dying people. Because if you don't talk about it, it's not happening. But it's happening. And finally, if all else fails, every hospital has what's called a patient care advocate. You call them and say, this is what I need. They can help you in the hospital. They can help you out of the hospital. And most importantly, if your doctor's not talking to you, get a doctor who will. Now, the final truth, the kind of doctor you are depends on the kind of person you are. But the kind of patient you are depends on the kind of person you are. So just like there's incompetent, nincompoop doctors, there's incompetent, nincompoop patients, there are. So your job is not to deal with either of them. So my next to the last thought is this. I was always taught that the sick don't inconvenience the well. Well, they inconvenience. Sick people are an inconvenience. But if you take care of them, if you show them mercy and compassion, you're doubly blessed. The best thing people can say when a death occurs is, I did everything I could. I mean, the grief is still there, but they did everything they could. Versus, I wish I knew. If somebody would have told me. And the very final thought is, you know, in Corinthians, Paul said, you know, we have a God of all comfort. Disease and dying doesn't always end well. And there is crying, there's suffering, there's pain. But we have a comforting God who can take care of us. And so, you know, prayer needs to be a big part of whatever you do. And with that, I'll take any questions you have. Thank you for listening.